Thank you very much for waiting. We now start the next session, Percutaneous Ablation for Liver Tumors, chaired by Dr. Hidekazu Kuroda, Dr. Hyunjo Rim, Dr. Liam Pin. Please.
Good morning, everyone. Welcome to Kyoto, Japan. Welcome to hot featured session, HCC1, Percutaneous Ablation for Liver Tumors. We have 4 presentators in this session. The moderators is Hidekazu Kuroda from Japan, Professor Hyunjo Rim from South Korea, and Professor Liam Pin from China. And the moderators, Professor Minami. Now, I would like to introduce our first presenter. Okay. Professor Kai-Wen Fang from National Taiwan University Hospital. Please.
Thank you. Thank you for your kind introduction. And hello, everyone. And I'm Dr. Kai-Wen Huang from Taiwan University. I'm also the educational chair of the ECTA. Today, I would like to introduce briefly about the percutaneous ablation for liver tumors in this region, Asia-Pacific area. As we knew, as the growing concept of the tumor local operation, we can find an indication of local operation is increased, including the very early stage and the early stage. And sometimes we will do local operation for intermediate status patient for selective situation. And however, this is a modality with a long history. As we knew, since 1916, cryo-operation has already been introduced. Then radiofrequency ablation, then modern microwave, then IRE. And until now, we have various kind of modality. We could deliver various kind of energy, physical power, including some light, ice, fire, electron, through the flow, through breath, through a microscope, through a needle into the tumor to treat the patient minimally invasively. So the current tumor operation for liver cancers, we could divide into non-thermal modality and the thermal modality. As for the non-thermal modality, we could destroy the tumor by radiation or electrical power, for example, IRE. And mostly, we use the thermal energy to destroy the tumor, include the higher temperature, heat-based thermal ablation, for example, radiofrequency ablation, microwave, laser, HIFU. Of course, we could use a very extremely lower temperature to destroy cancer cell, so-called cryotherapy. For now, the tumor ablation or liver cancers, the mainstream is internal cooling microwave or radiofrequency, including single or multiple probes, I believe was widely accepted in Asia-Pacific area. And the local operation is permitted to be used for even operable cases. That has already been introduced by Professor Shina, our chairperson this time, yesterday's keynote speech. And the local operation, not only for HCC, but also for liver metastasis of colorectal cancer, ovarian cancer, NET, with the intention to treat is widely accepted and recalled in various kinds of the guideline and consensus. Percutaneous ultrasound guide or CT guide is most popular and widely accepted, cheaper, rapidly, and efficacy and safe. And the local anesthesia during the procedure is common, but intravenous sedation is growing, especially in Taiwan and China, and more patients was treated under the intravenous sedation, even the endotracheal general anesthesia. And now we have lots of device in the Asia-Pacific area about the radiofrequency ablation device. And also we have the microwave ablation available, especially in China and the other country. The various kind of device and the generator was used. And some of them could ablate the tumor rapidly. And some of them could create a very big, huge ablation zone. And some of these devices could be used with a fine needle and multiple electrode, multiple applicator. And the various kind of size, caliber, and the length could be choice. And now the microwave and the IFA has also become the king of local operation. However, where to go for us? The trend of local operation for liver cancers, we could come to the conclusion about 4 items. Number 1, the more completed ablation. We try to enlarge the operation zone of local operation, especially the RFA. As we knew, the local operation size of RFA is quite limited. So now in this region, some doctors use the liquid spherical electrode in the tip of the device, could inject the saline, even the hydroxychloride, to increase the electrical conductivity around the tip to increase the ablation zone. But what's more popular is the so-called multiple electrode applicator, and by the switching controller or bipolar electrode application. As for the multi-probe ablation, is wide accepted in this region. That allows a non-touch approach, allows the simultaneously treatment of multiple tumors. We could do larger and more rapid ablation, and the current concept and the current technology encourage us to do bigger ablation zone for the bigger tumor. The multi-electrode with a switching controller could create large volume of tumor ablation by using the multiple electrode with a switching generator that could deliver the energy one by one or two by two electrodes. We could use 3 or more electrodes to deploy at a fixed space. Over the 25 minutes, we could perform a big operation, sometimes more than 6 centimeters. This is the data introduced from Taiwan by Chang'e Memorial Hospital, Dr. Lin Chenjun and Lin Ximin. They show the switch control with multiple electrode could use lesser time, but more if the electrode position. We can find the total operation time was reduced. The overlapping number was reduced. The electrode position number is reduced. It means it saved the time and decreased the possibility of complication. As for the outcome, the same group show the local tumor progression for the medium-sized liver tumor. The multi-electrode with the switching controller could prolong the local tumor, it would decrease the local tumor progression rate. And compared with the other group published by Dr. Kim and Dr. Morimoto, Dr. Lee in Korea, USA, and Japan, we can find the switch controller with multiple electrodes show a very powerful result to increase the efficacy. As for the overall survival, no matter before the propensity score matching or after that, the Chang'e Memorial Hospital group show the long-term survival to 5 years was improved from the 51% to 67%. It means when we change, we modify, we improve the device, we improve the outcome. Unlike liver resection, the surgical outcome is almost fixed. The excellent surgeon could reduce the complication rate, shorten the operation time, and make the whole operation rapidly, easily, and safely. However, the outcome is almost fixed, but we support the local operation has a very, very wide range of future. And the benefit of the multi-probe IFA, not only for the expand the operation area, not only for save the operation time, it could conduct so-called non-touch operation, just like a surgical philosophy. Before, we have to step into the tumor to create the operation zone, and then there's a possibility to become the threat, seeding or the metastasis. But now we could use the multi-probe IFA to do so-called non-touch operation. The tumor will not be stepped, and there's no risk of the local recurrence or the residual tract seeding, just like the Taiwan method by the chopstick. So the benefit of the multiple IFA could induce the non-touch philosophy, non-touch principle. This study was introduced by the Korea group by the 5 universities. We can find not only for the Dr. Seho in Europe, but also in the randomized control study in Korea. They show the tumor progression rate is decreased, and the global radiofrequency failure rate is decreased too. The second trend of local operation for liver cancer is a better ablation shape. As we knew, the ablation shape is not so satisfactory by IFA or traditional microwave. The ablation zone is a long roll like a hot dog or like a comet. Sometimes we will use the multi-tiny device. It will induce a very shallow disc-like ablation zone. Actually, it's unlike the shape of a tumor. It's not so spherical. And then the microwave ablation in these years have an evolutional modification. We can find through the thermal and the field control and the wavelength control, the ablation zone become more and more spherical. Better control, more spherical ablation zone, and more predictable. So now we could use, we can manipulate the different parameters, including time and including the energy, to ablate the tumor very completely. The ablation zone is very spherical and could cover the tumor from any direction. Not only for microwave, but also for RFA. This is a project in Taiwan, so-called the Sanctifier program. They try to modify the tip design and the tip material to increase the sphericity. We can find the result actually is quite good. And the sphericity will become the 3.2 over 2.8, around 1.14. And this is an improvement of ablation shape, not only for microwave, but also for radio frequency ablation. So the physicians try to perform the more useful ablation, more efficient ablation, but also we try to do the safer ablation. So-called safer ablation, we have to overcome the imaging limitation. We have to improve the tumor conspicuity. So the CT guide, after Lipiodol labeling, was raised by interventional radiologists in China, Taiwan, Korea, and Japan, everywhere. The radiologist could do very precise local ablation under percutaneous CT guidance. And also we use the contrast-enhanced ultrasound and the fusion image sonography, try to make the tumor clear, and we can see the adjacent organ and adjacent relationship between the tumor and the others. This is a study introduced by the Dr. Y.Y. Cho from Taiwan in VGH, and they found when they use the image fusion ultrasound, and the result is different from the traditional BMO ultrasound guide. We can find for this tumor operated by under the image fusion, the complete ablation rate is higher. Technical successful rate will increase with statistically successful. And what kind of image guide system of ultrasound became one very important successful parameters, and the odds ratio is 3.2 from 1.1 to 9.1. So we try to overcome the local ablation limitation, and the tumor location is used to be a big problem, especially for a tumor located over the liver surface or adjacent to the vessel or biliary tree. Now, for the tumor over the liver surface, we could do artificial ascites or intrapleural infusion assistance, or we could ask our surgeon, our colleagues, to perform the open or laparoscopic RFA to rescue this situation. When the tumor is adjacent to vessel or biliary tree, we could combine local ablation and alcohol injection, and we could also combine RFA and IRE for the risky area. And for this kind of tumor close to gallbladder and the highland area, we could do very perfect ablation by the current modalities. So we could expand our indication to some tumors that we could not and we don't dare to do ablation for them. We could use the modality beyond the thermal ablation, for example, cryoablation. It is an old modality developed earliest in 1916, and with a very extremely cold temperature, minus 100 to minus 135 degrees Celsius, to kill tissue by argon or liquid nitrogen. And the both gas was used now in Asia Pacific area. And then multiple probe frozen simultaneously according to the tumor size, so we could ablate a bigger tumor by multiple probes at the same time. The ablation zone is more predictable. We can find this kind of ablation is very clear, visualized under CT or under ultrasound guidance. And then now this method has already been proven to be a minimal invasive procedure, could be performed under ultrasound and the CT guidance. And for this ablation area, we have to overlap the tumor with the extremely cold area. With this area, the temperature should be lesser than minus 40 degrees Celsius. And for this kind of tumor over the risky area, we could perform cryoablation, and then we could find the vessel and the highland organ will be saved, will be spared very well. And the adjustment of the cryoablation for liver, is preferred for tumor in close proximity for this high-risky area and a relatively painless procedure. And the eyeball visualization is good. And the larger ablation zone could be performed by simultaneously multiple purpose and with ability to sculpt the shape and the size of ablation zone. What's more important with high potential is the so-called post-ablative immunomodulation. So in the future, maybe the immunomodulation could encourage us to perform cryoablation and the immunotherapy for liver cancers in the future. And the IIE is also another technique for the tumor over the risky area. It could increase the ablation efficacy by the electrical power. And we could ablate the tumor close to vessel, even overlap and encase the vessel. And where should for patient who have no other treatment option given the location of their disease. And the HPV cancer over the risky area has already been widely applicated in Taiwan, around more than 100 cases every year. It's also used in China, Japan, Korea, and even Thailand, Indonesia, India. And we could perform a hybrid IIE and the IFA to increase the therapeutic efficacy safely, decrease ablation time and cost. We could do IFA for the with marginal temperature monitor to perform the ablation for the safe area, and we do IIE for the risky area, close to vessel or the high-end portion. And we combine the two methods to ablate the big tumor totally. For example, this patient with a 3.7 centimeter HCC over the bifurcation of IHD, and we could do IFA for the safe area. We could do IIE for the risky area, and to perform almost the perfect operation for this risky area. And until now, we can find the potential trend of local operation was increased in market share value and in the clinical usage. And in the future, we believe it's still the same trend and situation for the next decade. So finally, let me come to a conclusion. My colleagues, the new device and the technique make a difficult operation possible and make the indication wider. However, there are still many skill challenges. Training and the continuous education is critical. So I believe there are lots of the medical centers in Asia Pacific area, including the center in Japan, in Korea, in Taiwan. Especially for the ECTA Educational Committee, we will try and devote ourselves to train and continuous educated doctor in this area. And the multiple electrode device, fusion imaging system with AI, AR, VR, and the combined treatment will prove to broader indication of tumor ablation. And I believe the improvement and the modification of this modern technique and the modern device will increase the application in the future. Continuous improvement of ablative technology will change the consensus and the real data. And I am looking forward to seeing more and more real data and the clinical trial in this region to improve even to change the consensus or guideline in the future. Thank you very much.
Thank you for your excellent presentation. Are there any questions or comments from audience? Minami, please.
Thank you, Fan. Very beautiful talk, so thank you very much. So I'm Yasunori Minami of commentators. So in Japan, the RFA and microwave is available. However, the cryoablation is not available. So you show the slides. You can use the RFA, microwave, and cryo. Yeah. Is cryoablation available in Taiwan? National insurance, does national insurance support cryoablation in Taiwan? Yes or no?
Yeah, no. Actually,
no.
The cryoablation was insurance reimbursed in Taiwan for kidney tumor, kidney cancer, renal HCC. For liver cancer, was not reimbursed. However, in Taiwan, let me focus Taiwan. Taiwan's insurance only cover for the small tumor by IFA, medium-sized tumor by microwave. Actually, insurance not cover every kind of tumor. For cryo-ablation and IIE, truly will be paid by patients themselves. Yeah.
Mainly used for HCC, RFA or microwaves.
Yes.
Yes. So when do you use the RFA? When do you use the microwave? I ask you the indication.
Okay. Actually, the indication is overlapping, right?
Yeah.
If in Taiwan, according to the national insurance, and we will ask the IFA for the smaller tumor, smaller than 23 centimeter, and the bigger tumor, we could pick up the multi-electrode IFA, we could pick up the microwave. Both will be reimbursed by insurance. However, what kind of the decision making of what kind of device depends on the experts in Taiwan. In Taiwan, I believe everywhere in Asia Pacific area, some doctors are major in microwave, some doctors prefer IFA, and of course some doctors could do it both. But I believe the education, training, and the experience of the single solitary doctor will be most important, most critical. If you do microwave, if you're comfortable and you could do it best for your patient, just do it. So there is the indication is overlapped now.
Yes, thank you.
Please.
Very excellent presentation, Professor Wang. I just wonder, with the patients with the liver disease, sometimes we have patients with limited functions of the liver, say maybe child with B7s or something. Yeah. So in this case, we have the risk of the liver failure after the ablations. What we can do? I mean, should we improve the liver functions before, or should we anticipate the liver function deterioration after the ablations after that?
Thank you, Dr. Kanin. And compared with the liver resection or the systemic treatment, I believe the local tumor operation actually is less harmful for liver function. So as you know, when we perform the liver treatment, liver resection, we have to do the liver function evaluation by ICG test or the others. But this was not encouraged for the liver tumor operation. So actually, I believe lots of the experts will do local operation for the patient with BCLC, with the child B patients. I believe that will be okay. However, through the application of a bigger and a bigger tumor, I also encourage if you want to do the massive operation for the tumor bigger than 5 centimeters, it's better to do the ICG test or the liver function evaluation. And you have to know what kind of vessel around this area will be sacrificed by your operation, and to calculate the potential liver loss after this procedure. Maybe the two patients cannot offer that. At that time, the local operation is also still risky for them. But for the small tumor operation, the local tumor operation always sacrifice very, very limited liver parenchyma. So I believe they will be saved.
Okay, yes, thank you, Professor.
Thank you.
Let's move on to the next speaker, Professor Shinichiro Nakamura from Japanese Red Cross Society and Society Himeji Hospital.
Thank you very much for your kind introduction. It is a great honor to be able to speak to you today. Also, I'd like to thank the program organizing committee for giving me the great opportunity to present our recent knowledge. I have nothing to declare for this study. The first, the background. Next generation microwave ablation has been developed as a new percutaneous thermal ablation therapy for hepatocellular carcinoma. Compared to radiofrequency ablation, microwave has the advantage of faster heating and less susceptibility to heat sink effects due to the higher temperature generated. It can also create predictable spherical ablation zones. In this session, I will discuss our microwave ablation procedure and the clinical outcomes of patients with HCC. We included patients who met these criteria. They were treated between September 2019 and October 2023, and their liver function was child A or B. The tumor diameter was no more than 4 centimeters without vascular invasion. Thus, 592 patients with 836 HCCs were included. This slide shows the materials and methods. Microwave ablation antenna puncture was performed under US guidance. When the tumor was difficult to visualize using beam ultrasound, we used contrast-enhanced US or fusion imaging with CT or MRI. We use artificial broiler effusion or ascites when the tumor is adjacent to other organs. We use mainly the imprint system and sometimes a MIMAPRO system. US apparatus is Aprio i800 Canon, Japan. This slide shows the primary devices we use. This slide shows the primary protocol for ablation. The upper row is for tumors larger than 15 millimeters in diameter, starting at 60 watts for 1 minute and 75 watts for 1 minute, and then increasing to 100 watts in 3 steps. The lower panel shows a smaller tumor, less than 15 millimeters in diameter, and after 6 watts for 1 minute, the power is increased to 75 watts for a few minutes while monitoring the extent of the bubble. We usually use the following basic techniques. In the next section, I will illustrate each technique by presenting cases. The first basic technique is artificial ascites. A 90-year-old male, with 14 millimeters HCC in segment 8 just below the diaphragm. MRI image before ablation showed 14 millimeters HCC at the top of the higher lobe of the right lobe of the liver. Here I show you how we prepare artificial ascites before ablation. We inserted the Verus needle into Morrison's fossa and injected 1 liter of 5% dextrose solution. Here's the tip of the Verus needle. Then at first the tumor was difficult to see, but after the ascites injection, we could see the tumor clearly. We ablated the HCC with imprint by maximum power at 75 watts for 3 minutes. We can see the tumor in hypoechoic lesion here. The left panel shows the before image, and the right one shows the MR image after ablation. The coagulation zone showed a high intensity signal in the T1 weighted image, and a sufficient margin was obtained. The second basic technique is artificial broiler effusion. This case is a 73-year-old male with 15 millimeter HCC in segment 7, just below the diaphragm. CT and US images before ablation showed 15 millimeter HCC at segment 7, just below the diaphragm. This movie shows how we prepare artificial broiler effusion before ablation. We inserted an 18-gauge elastic needle into the thoracic cavity and 500 millimeter to 1 liter of 5% dextrose solution. Then we ablated the HCC with imprint by maximum power at 100 watts for 5 minutes. This ablation was performed by a young doctor working with microwave ablation for 2 years. The left panel shows the before image, and the right one shows the MR image after ablation. The coagulation zone was sufficiently obtained. Well done, Dr. Murakami. And the third basic technique is contrast-enhanced US. We present a case, 80 years old female with HCC. This patient had a 12 millimeter HCC at segment 6, very tiny lesion. This slide shows a fusion image. The left panel shows MR's MPL image, and the right panel shows the US image. We found a slightly hypoechoic lesion in segment 6, but there are many hypoechoic nodules around this lesion, so it was unclear compared to the MR image. This slide shows how we use sonazoid. We observe the vascular phase for 1 minute from the injection of 0.5 milliliters of sonazoid suspension. Then we can scan the liver in the post-vascular phase after more than 15 minutes, usually 30 minutes from the injection. This movie is a CUS movie of this nodule. This patient, this nodule is stained in the early arterial phase and washed out clearly, this one, in the portal venous phase. Nodal washout is becoming more apparent in the portal to late vascular phases. Now we can confirm the tumor as the HCC from left to right, phase inversion, amplitude modulation, tissue harmonic with a low mechanical index. I will show you the difference between these three modalities. This slide shows CUS images 1 hour after sonazoid injection. This period is called the Cooper phase, and the tumor is observed as a non-enhanced lesion. Tissue harmonic with a low mechanical index mode has nearly twice the frame, 27 frame per second, and the frame rate and higher resolution than other methods. Then we usually use this tissue harmonic with a low mechanical index mode for ablation. The patient was placed in the spine position and punctured from the right intercostal space. The left panel shows captured CUS volume data, and the right panel shows the real-time CUS image. After penetrating the tumor with the antenna, we started ablation, 60 watts for 1 minute and 70 watts for 3 minutes. The entire tumor was surrounded by a bubble. This slide shows the MRI images 2 days after ablation. We achieved complete necrosis of the tumor. The overall patient background is shown on this slide. The median age was 77 years old, and the most common background of liver disease was HCV, which was 340 patients, almost 57%, followed by non-viral liver disease, which is 34%. The median tumor size was 14 millimeters, and about 70% of the patients had a single tumor, and 25 were treated for the first time. In many cases, artificial ascites are required as hydrodissection to maintain the distance from the adjacent organ in the case of microwave ablation in our department. We have used artificial ascites 56% of cases in total. The cumulative local recurrence rate for all treated nodules is shown. The cumulative local recurrence rate at 4 years after ablation was 8.9%. The local tumor progression rates at 4 years after ablation were 6.7% for tumors less than 20 millimeters, 15.8% for tumors less than 30 millimeters, and 32.5% for tumors larger than 3 centimeters. The results suggest that the tumors less than 30 millimeters are a good indication to microwave ablation. This slide shows the tumor locations at so-called difficult to ablate locations. 45 near the heart and 42 adjacent to the major portal vein and 30 around the IVC and 29 attached to the gallbladder and 18 at the carotid lobe. Here I show you one case. A surgeon referred us to this case of HCC, this nodule. The surgeon referred this patient to me. I didn't say I wanted to do it, but the tumor is 28 millimeter in diameter at segment 5, had a large protrusion adjacent to the gallbladder. This slide shows the fusion of the CT and US images before ablation. You can see how the tumor with a lot of blood flow is compressing the gallbladder wall. Here is gallbladder and the tumor is here. We set the fusion markers, multiple fusion markers at the center and peripheral region of the HCC. We then ablated the tumor, carefully watching the ablation bubble at each site. Finally, we punctured the tumor 5 times and ablated for 17.5 minutes at maximum power 100 watts. This slide shows the image before and after ablation. We achieved a complete necrosis of the HCC without any complications. And this patient was no local progression after 3 years of this ablation. A cumulative local recurrence rate per nodule grouped by difficult to ablate locations or not. The cumulative local recurrence rate at 3 years after treatment is 12.9% for difficult to treat locations and 6.9% for other locations. There is no significant difference between them. When the Cox proportional hazard model was analyzed, the factors contributing to local recurrence, tumor size, ablative margin, and AFP-L3 were extracted as significant factors in the univariate analysis. And tumor at difficult to ablate locations was not associated with the local tumor recurrence. Post-ablative complications occurred in 41 cases, 4.9%. Biomas were observed in 11 cases, portal vein thrombosis in 9 patients, bile duct dilation in 6 patients, pleural effusion in 5 patients, and so on. Except for 1 patient with liver abscess who received percutaneous drainage, all grade 1 or 2 and treated conservatively. Logistic regression analysis was performed for factors contributing to complications. Difficult to ablate locations were a significant factor in the univariate analysis. Still, only tumor size was an essential factor for the multivariate analysis, and the difficult to ablate locations were not significant. This is a summary slide of my presentation. 4 years after ablation, the local tumor progression rates are 6.7% for tumors less than 20 millimeters, 15.8% for under 30 millimeters, and 32.5% for more 30 millimeters. The factors contributing to local recurrence were tumor size, ablative margin, and AFP-L3. Post-ablative complications occurred in 1 case, where tumor in 41 cases, 4.9%. The only tumor size was significantly associated with complications. and difficult to ablate locations was not a significant factor for the local recurrence and complications. Here is our conclusion. Microwave ablation is a safe and effective local ablation therapy for HCC, even for tumors in areas of the liver where local ablation therapy is difficult. Now, first I'll introduce my town, Himeji, where my hospital is located. Himeji is a city in Hyogo Prefecture in western Japan facing the Seto Island Sea. Himeji is located 100 kilometers west of Kyoto. And Himeji City is famous for Himeji-jo, a World Heritage Site, and our hospital is located about 6 kilometers west of it. This is my department. Welcome to Japan. Welcome to Kyoto. If you have time this weekend, please come to Himeji. Thank you.
Thank you very much for your excellent presentation. Are there any questions and comments? Professor Minami, please.
I'm Dr. Minami. Thank you, Professor Nakamura Sensei. So thank you for showing your beautiful technique on slides. So as you know, the device of RFA and microwave is available in Japan. So I know you use the microwave in almost cases. May I ask you a question? Why do you like microwave device?
Thank you, Dr. Minami. I prefer microwave rather than RFA because if we can place the needle right area, right location, the ablation zone was very secure, and we predict the ablation zone in advance. So I prefer microwave rather than RFA. That's the reason.
Thank you.
Yes, next question.
Thank you very much for a wonderful presentation and amazing technique. A short question. How do you determine the ablation margin? Is it by follow-up image or you use fusion image during the ablation?
You asked the after ablation.
In your analysis, you put the ablation margin into the factor. So how do you determine your ablation margin?
We measure every slice and every corner view slice, and the minimal ablation margin was recorded at the ablation margin.
So that's determined by the follow-up image after the procedure, right?
Yes, okay. one day or 2 days after ablation.
Thank you.
Thank you.
Hi.
Thank you. Dr. Zhang from Taiwan. So thank you for your next meeting. So I'm wondering about your experience. So we can visible the junction of the needle to the ceramic part only, the hyperechoic part. So I wondered how to place this part to the safe, to the high risk location through the exit or through the tumor to the high risk location tumor. How can you apply it and place the needle?
Yeah, as I show you in the slide, the tip of the needle, the right tip of the needle is, we can see the...
This is the junction, that's the tip.
Yes, very small point and high echoic point, we can see the very high echoic point as the tip of the needle. So we puncture the tumor and through it and 2 or 3 millimeters over, and then start ablation.
So it's through the tumor. It's still through the tumor. Okay. Thank you.
Thank you.
Hi, please.
Thank you. I'm Dr. Chen Jinlin from Taiwan Chang'e Memorial Hospital. I have 2 small questions. The first is, because you include the tumor medium size, such as for the 3 centimeter to 4 centimeter. So for such kind of tumor, do you use overlapping more than 2 approach for the tumor? And second, have you encountered the complication of the needle tip broken in the patient body when you use the microwave?
I'm sorry, I didn't catch your
The
first
first
question.
is for the larger tumor. Do you use overlapping approach? Use two approach for the tumor.
Yeah, two
or three approach.
three. Yeah, in many cases we usually only single session, but sometimes such as the adjacent to gallbladder case, we puncture 5 times, and we ablate first ablation, then the bubble was surrounded around the tumor, and we can't see the tumor clearly, so we wait for 5 minutes or 10 minutes after ablation, and then the bubble was cleared, then we start second ablation.
Yes. The second question is, have you encountered complication of the needle tip broken in the body, patient body?
No, I never experienced the needle broken case. Thank you.
Okay, thank you for presentation and excellent talk. Next, we will be next speakers. Okay, such speakers, Professor David Craig Madoff from Yale School of Medicine, USA. Please.
Thank you for the invitation. I'd like to thank Professor Sheena. It's really, in my opinion, very exciting to see that percutaneous ablation of liver tumors is highlighted so well at a more general hepatology meeting. So I'd like to thank everybody for that. So what I'm going to talk about is maybe what should be in the next session, which has to do with drug therapy and whether it should be whether classical local treatments can coexist. This is my disclosure. So as you've already heard, there are many types of ablation modalities available. Ablation, the goal is to percutaneously eradicate all viable malignant cells while sparing normal surrounding tissues. We can treat tumors that have, in fact, unfavorable locations or patterns of distribution for resection, and/or patients that have multiple comorbidities that don't allow for that. Most patients are treated with low-volume disease, and sometimes it's used for debulking, and typically, at least in the US, it's typically done as an outpatient and is repeatable. Now the question becomes, are there other indications for ablations besides this standalone therapy such that we can actually achieve curative intent? So this is a study that I wanted to show looking at overall survival and recurrence with RFA. Here, they looked at repeat hepatectomy versus percutaneous RFA for patients with early-stage recurrent HCC, and what they found was repeat hepatectomy is associated with better local disease control and long-term survival in patients that have HCC that have a diameter of greater than 3 centimeters or an AFP of greater than 200 nanograms per ml. So based on this, we think we can do better. So how can we leverage adjuvant and neoadjuvant treatments to improve oncologic outcomes with ablation? So there's lots of different types of adjuvant and neoadjuvant therapy. There's chemotherapy, there's targeted therapy, and there's immunotherapy, and we're going to discuss all these in brief. So I just wanted to go over the rationale of combination therapy in oncology. This is not a liver study, but it is one that does highlight the benefit of combination therapy. So here, they looked at 3 randomized clinical trials that were pooled for combined analysis, and what they did was they assessed the efficacy of fluorouracil and high-dose folinic acid after surgery for Duke's B and C stage colon cancer. And what they found when they were looking at the mortality of the combination group is they they got reduced mortality, statistically significant, with the combined therapy over fluorouracil alone, better 3-year event-free survival, and also a better overall survival. So what they really concluded was that fluorouracil and high-dose folinic acid is a well-tolerated and effective treatment for patients with colon cancer that is better than either treatment alone. Now, we all know that chemotherapy is not the greatest option for HCC. However, there has been use of combination therapies now for years. And here we see a meta-analysis of 6 randomized controlled trials where TACE and RFA has been found to now be associated with significantly longer overall survival and recurrence-free survival as compared to RFA alone. However, I would say that the incidence of major complications with this combined therapy did not reach statistical significance. So what we now believe is that in patients with HCC, TACE and RFA can be performed together to get this higher overall survival and recurrence-free survival. And again, there's really been no significant differences found in major complications. Here we see another type of tumor within the liver. This is unresectable extrahepatic cholangiocarcinoma. And in these 3 studies, you can see that the patients either got RFA plus chemotherapy versus RFA alone, or they got RFA plus chemotherapy versus chemotherapy alone. And all these studies show that the combination of RFA with chemotherapy leads to an improved overall survival in extrahepatic cholangiocarcinoma. And this is specifically true, or particularly true, in patients that have no distant metastases. And then in colorectal liver metastases, we can see in this single institution of 30 patients where they had colorectal cancer with liver metastases, they had systemic chemotherapy plus RFA of lesions. And what they found was they had better response rates with the combination therapy, plus they got improved response rates plus overall survival. So in these situations with chemotherapy, you can have systemic chemotherapy plus RFA being safe and effective in colorectal cancer patients with liver metastases. But of course, as we always say, especially in a cohort of 30 patients, we really need larger scale studies. And then lastly, just wanted to highlight again the fact that chemotherapy in combination with ablation is something that's really been highlighted, unfortunately not necessarily in the setting of HCC, but this is a study now being done with pancreatic locally advanced unresectable cancer called the Pelican trial, where they're looking at RFA plus chemotherapy versus chemotherapy alone. And here we hopefully will see that there is a benefit of doing RFA or ablation in general with combination therapy. Again, it's very rare to see studies that have just chemotherapy with RFA in the setting of HCC. So, but I just wanted to highlight that these things are being done in other cancer types. We also want to look at targeted therapy. The idea here is that we can take this targeted therapy to develop agents that target specific molecules or genetic mutations involved in cancer development and progression. And these targets may in fact include proteins, enzymes, or other molecules that play crucial roles in cancer cell growth and survival. We can combine these targeted therapies with other cancer treatments, whether it be chemotherapy, radiation therapy, immunotherapy, local regional therapy such as ablation, to enhance the overall treatment efficacy. And hopefully by using these multimodality approaches, we can reduce tumor burden, enhance local control, overcome tumor heterogeneity, and also resistance to targeted therapies. Now, this is a case that was very similar to Professor Sheena's presidential lecture. And in this case, they showed that sorafenib may in fact lead to significant improvement of progression-free survival and overall survival in patients with advanced HCC. So we see here to the left that the patient originally had a 13-centimeter mass in segment 8 with tumor thrombus and a really bad prognosis. Patient was given sorafenib. The tumor reduced in size considerably. The patient then had a nodule, which you can see that was then treated with ablation. And now this patient has a very good outcome and is now disease-free. So just looking at this, we can see that in this case, sorafenib was used to downstage advanced HCC for local regional therapy that can aid in achieving complete remission. And hopefully by doing this, we can get get treatment responses looking at both imaging and serum tumor biomarkers. So hopefully this is another option that can occur. Here we see a study on recurrent HCC. This is a retrospective multi-center cohort of 363 patients where they had intermediate stage. Some of the patients got TACE and sorafenib, and others got TACE, sorafenib plus RFA. And they were looking at overall survival, progression-free survival, and tumor response, comparing the groups with propensity score matching. And as you can see, when we look at the overall survival and the progression-free survival, there definitely is statistically significant differences in the group that had both the TACE, sorafenib, and RFA. So they concluded that patients that underwent TACE and sorafenib plus RFA was superior to TACE and sorafenib alone for intermediate HCC, which includes longer overall survival and progression-free survival. However, they did note that patients that had good response to TACE from the start and were downstage successfully did not really benefit from the ablative therapy. And then here we see a small study of 22 patients with Child-Pugh A, BCLC B2 HCC, and actually were beyond the up to 7 criteria and had no history of systemic treatment. So all patients had lenvatinib for at least 2 weeks. Some had monotherapy. That was 9 patients, and 13 patients, and 9 patients had a combination of lenvatinib plus RFA, and they were looking at tumor response and prognosis and possible adverse events. And what they found was that there was definitely better overall response rates, as well as median overall and progression-free survival compared to with the combination therapy. And they also found that there were no statistically significant differences in terms of overall adverse events. So this is another way of highlighting the use of targeted therapy. And then lastly, this is a study that looked at 59 patients with HCC. There was between 2 and 3 centimeters in diameter and no history of systemic treatment. And the patients underwent courses of lenvatinib and then were treated with RFA as an add-on therapy. And ultimately, they compared RFA to the combination therapy, looking at popping frequency, which is a way you can assess tumor destruction. So if you feel these pops, it actually means that you may have much better, there's like an explosion of the cellular material within the tumor cells. And what they found was that the popping frequency was significantly higher in the combination group than in the monotherapy group, and that there were no differences in combination and monotherapy in terms of ablation time, maximum output levels, tumor temperature after ablation, as well as initial resistance values. So they concluded that popping frequency significantly was higher in the combination group, and that this intratumoral temperature increase may have been due to the fact that lenvatinib has an effect on tumor angiogenesis. So that's something that we really need to look at in the future as well. But they did not include survival. So this is just a response kind of thing. Now, I wanted to focus the rest of the talk on ablation and immunotherapy. As you're all aware, immunotherapy was first published on back in 1927 with BCG in bladder cancer, and interestingly, it's still used today for this indication. The criteria that is used for successful BCG therapy was that they had a host capable of mounting an immunologic reaction to antigens. They had a limited tumor burden. They had adequate number of BCG organisms, and they also had close contact between the BCG and the tumor cells. So these are areas that we really could focus on, whether it be transarterial therapy or ablative therapy or other types of therapy. So local regional therapy, in fact, can shape tumor immunity by altering composition of the tumor microenvironment. So what we can get is necrosis of tumor cells that then lead to a release of tumoral neoantigens, and then the recruitment and activation of dendritic cells into the tumoral, into the microenvironment. So we can see that in the middle picture, that this is a non-inflamed tumor. I guess we'd call it a cold tumor, and it has limited benefit when using immunotherapy. However, you can see when you add TACE or RFA, you get an increase in antigen release, increase in pro-inflammatory cytokines, and other factors such as increased VEGF, HIF-1 alpha, et cetera. So what we can use local regional therapy for is to transform immunosuppressive microenvironments that are non-conducive to checkpoint inhibitor therapy into immunosuppressive settings that make the systemic therapies much more effective. Now, this is just to show in HCC that immunomodulation mechanisms of local regional therapy is exceedingly complex. Now, various local regional therapies have different mechanisms, whether it be immunostimulatory or immunosuppressive. What I would say in our animal lab, we've done a lot of work, for example, on embolic agents, and you can tell that depending on which embolic agent you use, they have very different impacts on the immune system. And the same goes with ablative therapies. Now, the reason why I bring this up is that it's really critical to understand these mechanisms when planning a clinical trial that combines local regional therapy with immunotherapy. And this lack of awareness, and that's also not getting interventional radiologists involved in clinical trials at the early stages of clinical trial development, actually may lead to introducing confounding variables. So I think that this is something that we really need to look at. Now, this is just a laundry list of the different immune stimulation and suppression effects of ablative therapy. I'm not going to go into the whole laundry list here, but suffice it to say that we really need to focus on both innate immunity as well as adaptive immunity. Here we see a study looking at innate immunity where they look at inducing the stimulation of natural killer cells with RFA. So you can see that in the very beginning, before the RFA, it's a very low level of cytotoxicity, but when you do RFA at 1 week, it stays kind of the same, but then at 4 weeks, you can see a tremendous increase in the amount of natural killer cell cytotoxic effect by doing radiofrequency ablation. And here we can look at adaptive immunity, which is to increase the number or increase the number of circulating tumor-specific T cells. So here we see in a study of 20 patients with HCC before and 1 month after RFA that this immune response after treatment results in an increase in responsiveness to either the tumor antigens from the untreated HCC tissue and the necrotic tissue, leading to higher frequency of circulating tumor-specific T cells. Now, this T cell response can be sustained, and as you can see, it can recall antigens that have been also significantly augmented. So this study really concluded that RFA can induce circulating tumor-specific T cells that I think we're going to be very interested in targeting. So in terms of a clinical rationale, we really need to look at ablative therapy and how it affects the immune response. We need to look how the immune activation is seen in the tumor microenvironment, and then come up with combinations where immune therapy can actually improve overall outcome. So I wanted to just show some studies that are evaluating the combination of ablation with immunotherapy, and I'm actually just going to focus on these three. This was a study of 32 patients with treatment-refractory HCC. They gave tremelimumab at 2 dose levels for every 4 weeks for 6 doses. And then on day 36, the patients underwent either subtotal RFA or chemo ablation. And what I just wanted to highlight here is that 12 out of the 14 patients with quantifiable HCV virus had a marked reduction in viral load, as well as at the 6-week tumor biopsy point, they had a clear increase in CD8 T cells. So this just really shows again that we can enhance immune response by giving combination therapy. Here we see a study of 127 patients who underwent anti-PD-1 plus RFA versus RFA alone. They used matched cohort comprising 40 patients from each group that was selected after propensity score matching. And what they found in this study was that the 1-year recurrence-free survival rates were statistically significantly better with the combination therapy. And then on univariate and multivariate analyses, both the 1-year recurrence-free survival and the overall survival were involved with anti-PD-1 treatment. So this really shows that having immunotherapy on board does help with 1 year recurrence-free and overall survival. And they did find that they did have some grade 3 and higher adverse events, which was only seen in about 13% of patients. And then the last study I just wanted to show is a study of 59 patients that underwent curative surgical resection or RFA for stage 1 or 2 HCC. This was done at 2 large volume Korean centers where they received adjuvant cytokine-induced killer cell immunotherapy. And they also did propensity score matching. And they were also looking at the endpoint of recurrence-free survival and as well as overall survival and safety. And they found on univariate analysis that the immunotherapy group was significantly longer in terms of recurrence-free survival. And on multivariate analysis, the immunotherapy was an independent predictor of HCC recurrence. So I think we know what we're seeing here. Now, what's the most appropriate strategy for development of clinical trials? Well, right now, we really don't know. We don't know if we should be looking at neoadjuvant therapy, adjuvant therapy, maybe they should overlap. We don't really know. But there's a whole list of unanswered questions that I think we need to address in the next, over the next maybe decade. And they include the following. Which treatment modality is actually more immunogenic? Is it ablative therapy or is it transarterial therapy? What is the extent of therapy required for successful local regional therapy? We talked about complete ablation in every other talk, but we also mentioned subtotal ablation and how would you do that, why would you do that, et cetera. What's the best timing for immune checkpoint blockade before, during, or after local regional therapy? And then how do we actually define the biomarkers of response? Is it by tumoral biopsy or is it from the peripheral blood? What's the best delivery mode for immunotherapy? Should it remain systemic? I know there's a lot of interest in intratumoral injection as well. And then we should focus on the effector cells or immune suppressor mechanisms in the microenvironment. So I think there's a lot of work to be done. Now, I just wanted to end by showing this one study that combined ablation with both targeted and immune therapy. And this is, as you all know, the IMbrave 050 trial. And this was actually the first adjuvant regimen showing statistically significant and clinically meaningful benefits in recurrence-free survival after both surgical resection or ablation. Now, some patients received atezo-bev, while others just underwent active surveillance. But this shows that there was a benefit to the targeted immunotherapy combination following resection or ablation. So I just wanted to conclude here by stating that combination therapy does seem to have a better response in overall survival rates than each therapy alone. We do need to now focus on personalized treatment, whether we tailor to genetic and immunological profiles. We need to look at novel combinations by exploring various ablative and systemic therapeutic treatment options. We need to also look at improved delivery methods. So we already heard a lot about advances in ablative techniques, but we also need to look at different drug delivery systems and vehicles. And then we also need to do a lot of ongoing clinical trials to evaluate the safety, effectiveness, and timing of systemic therapies when combined with ablative therapy. So thank you for your attention.
Thank you for a very interesting presentation. Is there any question, comment from audience? Professor Minami, please.
So I'm Yasunori Minami. So thank you for your excellent talks. So there are, there are two types of combination ablation and chemotherapy, adjuvant and neoadjuvant. And in addition, we have two choice of chemotherapy, TKI or IO drugs. I'm sorry for my tough questions. Please tell your opinions. What is the best combination, ablation and chemotherapy, and how to use it at present?
Yeah, that's a very difficult question because I think I said on my last 2 out of 3 slides that these questions have yet to be answered. And we really don't know. And that's why, we get involved in a lot of clinical trials, whether it be TACE and immunotherapy. I've been involved in one that the immunotherapy was given first. for 2 weeks, and then we did the TACE. There's another one that, the Emerald one is actually the other way around, where you do TACE followed by immunotherapy. So, and the same would go with ablation. So at this point, a lot of work needs to be done. And unfortunately, at this time, I really don't have an answer because a number of clinical trials that are out there at this point are still relatively small and the data is not mature.
Thank you.
Thank you. Any question? I have one question, okay?
Sure.
Alpha introduced natural killer cells and specific T cells. What do you think about what is best timing for immunotherapy after radiofrequency ablation? Timing?
Well, we don't, again, we really don't know. I mean, we could even do it concomitantly. Like it's hard, like there is no, like I don't want to sound like I'm hedging, but I guess I have no choice because there is no answer to this question yet.
Yeah, thank you. Okay. Okay. Thank. Please.
David.
Sorry. Yes.
Okay, and I would like to hear your comment about combination therapy after systemic or immunotherapy combined with intervention. And in Asia, especially in Japan, we Japanese doctor cannot use Y90 radioembolization. But in your Western country, you can usually choose radioembolization or liver transplantation. So, and you have already said the data is still immature. How about, I would like to hear your comment about selection. So after effective systemic therapy or immunochemotherapy. So
in terms of Y90? Or in terms of
Y90, especially in the Y90.
Well, it's very interesting because Y90 has grown significantly in the US, but I would say that it's not grown in other parts of the world, despite the fact that they claim that the results are better just without immunotherapy. You know, and it only comes from a handful of centers that say this, but they're very, very vocal. I showed a couple of days ago that there's now something called radiation segmentectomy, where you can do a very high ablative dose instead of doing ablation. Okay, so you basically can do a very high dose Y90 to 1 or 2 segments of the liver, and basically kill the tumor with very high levels of radiation. Okay. That's a very complex topic as well, because nobody, and right now, the only study that, in terms of the question of immunotherapy, the only study that really showed any benefit at this time that we know of is the Emerald 1 study, which is TACE. So with Y90, the data is still out. We don't really know, but some of the studies are going to be coming out very soon, and it's hard to say.
Okay, thank you.
Sorry, time is limited. Thank you for David. Let's move on. Next presentation. Professor Hyun-Chun Lim, Department of Radiology from South Korea. Please, presentation.
Thank you for your kind introduction. Actually, we are quite behind schedule, so I'll try to be brief. Can I see my slide? Okay. Good morning. First of all, I'm very happy to meet all of you at this wonderful place in Kyoto. It's my great honor to be invited to this wonderful meeting, APAS meeting, actually at the birthplace of local regional treatment, as we all know. In the 80 minutes, I like to talk about strategic optimization for percutaneous liver ablation. Thanks to the Asian Society of Tumor Ablation members, we made sound evidence on curative ablation. As you can see, almost half of papers was published from Asian countries, including the famous SURF study. As you can see, there was no significant difference, even recurrence-free survival between surgery and radiofrequency ablation. So ablation is accepted as a curative treatment option for early-stage HCCs in most HCC treatment guidelines, including APASL and KLCA NCC guideline. Again, in most HCC treatment guidelines, ablation is the curative treatment for early-stage HCC, even if surgically resectable. We should be proud of it. However, in most treatment guidelines, only tumor size and tumor number are mentioned in the guidelines to assign the proper weapons. However, any weapon cannot guarantee the best patient outcome if we don't use accurately and smartly. Many more things should be considered for the best outcomes of ablation. Now it is time to get a consensus on strategic optimization of our liver ablation. A strategic optimization involves a personalized methodology beyond just conventional practice. By incorporating advanced technology and tailored patient care, we can boost precision and procedural efficacy. Individualized treatment plans, guided by enhanced imaging, enable accurate tumor delineation and minimize collateral damage to healthy tissue. As we all know, there is a proposal for standardization of terms and reporting criteria, but it is time to provide more practical recommendations for liver ablation. Recently, Korean Liver Cancer Association initiated expert recommendation for liver ablation, including all the essential parts for ablation, including indication to the post-ablation strategy. We will submit this document in this year's, and you can see this document in Journal of Liver Cancer soon. Moving on, strategic optimization. I think, as we all know, the most important thing, careful selection. To achieve the best outcome, we should understand pros and cons of our local ablation. Besides just location, we carefully consider all the details regarding patient and tumor and operators, including energy source. There are so many things to be considered. The final magic bullet for selection, as we all know, multidisciplinary approach. Please discuss with your colleague for the final decision. According to our study, you can see the multidisciplinary approach can improve the patient outcome. Next is a precise planning. I would say planning is almost half of the procedure. Please decide all the details in advance at planning phase. including approach, position, guidance, energy source, ablation parameters, and assistance techniques, and combined treatment with TACE or ethanol injection. And define the target ablation zone depending on the tumor size. The microwave is a mega trend, but RFA is time to retire. I would say not yet, because of no survival inferiority to microwave ablation, and also we can use the no-touch RFA technique. When do I use microwave and radiofrequency ablation? My answer is the exit of a tumor today. If you look at the many catalog, they don't tell the tumor, they only tell the ablation size and configuration. But we should remember the tip of electrode should be placed at least 5 millimeters beyond the tumor. So I would say the exit is the posterior margin of the tumor, entrance of tumor, and the exit of tumor. It is very important to choose the applicator. Exit tumor is defined, a tumor with a 5 millimeter, more than 5 millimeter space. This is a good example. If the tumor is an exit tumor, it is easy to make the sufficient posterior ablative margin. But as you can see, there are many more tumors don't have the exit. That's the problem. Good example is a subphrenic, subcapsular, and perivascular tumor. This is a typical example, no exit tumor. For no exit tumor, it is hard to achieve posterior ablative margin. And also, we can make more complication. No exit tumor. If we insert electrode more deeply, we can encounter the complication. So there is a dilemma between the complication and insufficient ablative margin. So in my practice, if the tumor is a conspicuous and with the exit tumor in safe location, currently I prefer the single microwave ablation. But otherwise, I more prefer to use multiple radiofrequency ablation. And also, we should expect the potential complication from bleeding to abscess, and also rehearsal the procedure in mind and refine the final planning. And make a document on the plan in your medical record. Again, planning is the half for successful ablation. The careful selection and planning. The third is the accurate and optimal ablation. It is time to move from just bigger and quicker ablation to more accurate and optimal ablation. Everything sometimes could be critical, even from the skin puncture side, I think. So please choose the best applicator path for the best configuration of ablation volume, zone, and optimal ablation volume. They're very important. Before starting the ablation, please ask yourself, is it accurately placed? 3 times ask yourself, are you sure? If the answer is a surely yes, at that time, push the button. Because, as we all know, the Sony window must be getting worse just after the starting ablation. So before starting ablation, we should do everything. For accurate and safe ablation, as we all know, there are many novel techniques: fusion, contrast-enhanced ultrasound, and artificial fluid. There are so many literatures proving the benefit of this kind of novel technology. So I recommend, if there is any potential for thermal ablation or tumor is not conspicuous, we should use the fusion, artificial ascites, or artificial fluid. Let me show you our two cases using the novel technology. How I make artificial ascites. We use angiography introducer sheaths rather than spinal needle.
This could be the best thing that I'll ever know.
I insert angio sheath needle in the breathe-in state, just subcapsular portion 1 centimeter. After that, I instruct the patient fully breathe out. In most cases, the liver is displaced upward. The angio sheath, needle sheath placed in the perihepatic space like this. At that time, we can insert guide wire and change it with dilator. This is much easier and effective to make artificial ascites in a short time. We don't drain of ascites anymore. And usually portion window, change it in 2 to 3 minutes. We can apply more accurate ablation. Insertion, approaching the tumor, and then the yellow circle means the tumor boundary, red circle means the target ablation volume. So we have to wait until the echogenic zone approaching the red circle. This is I think, best way to achieve the circumferential ablative margin by monitoring of ultrasound. Needle tract cauterization, and there is no bleeding. Compared to even laparoscopic approach, it is minimally invasive. Immediate post-CT. The second case is artificial pleural effusion. There's a 2 tumor in segment 7, quite difficult area, for bare area actually. We use the 17-gauge epidural needle like this. Usually using the 200 milliliter, we can get a better sonic window like this. So ablation from the deeper portion using the multiple electrode and move to the superficial portion. And you can see the ablation zone is quite satisfactory. So artificial ascites and pleural effusion is essential to minimize thermal injury and increase the sonic window. Optimal is better than just excessive and extreme ablation. Let's save our poor liver. Because many more treatment will be surely coming near the future, because HCC continuously recurs until the patient life. Next one is a post-ablation imaging. This is also very important. Please take your time to evaluate post-ablation imaging regarding ablation zone, size and configuration, optimal, excessive, and insufficient, or ablative margin, circumferential versus eccentric, or immediate complication from bleeding to pneumo or hemothorax. And also, please have a time for self-Q&A, just review. Please ask yourself, placement of your applicator was really accurate as you planned? Ablation zone is similar to your plan? Was it excessive or insufficient? Why? Ablative margin, circumferential or eccentric? Why? Any mistake compared to your original plan? Any unexpected event or complication? Why? What did you do? What did you miss the planning or procedure? How will you do if you have the same patient next time? What is the lesson from this case? I know everybody in this room we should do this kind of procedure step, but very important, and compare the post-ablation result with the original plan and find the difference between the both and think about the reason. This is very important. Write down in your diary what you have done well, what you have done wrongly, what was your mistake, what you have learned from the case. Please repeat what you have done well. Please don't repeat your first mistake, and please share any lesson with your colleague. Okay, finally, the basic forever. We are living in the era of the immunotherapy. So how do you think, what is the future of ablation in the era of immunotherapy? Actually, at the moment, I have no idea. As we all know, there are so many studies ongoing regarding local regional treatment with immunotherapy and also adjuvant immunotherapy after local regional treatment. We should wait for final conclusion. I'm looking forward to seeing the promising results soon, hopefully in 5 to 10 years. Maybe following the next 2 sessions, the many speakers are preparing the many answers in details. Please enjoy it. Don't forget, the success of almost all procedure depends on the basic, rather than just a novel technology. Basic includes very simple careful selection, precise planning, accurate and optimal ablation, and post-ablation assessment. Novel technology is necessary for the better outcomes from fusion, CUS, artificial ascites, no-touch ablation, immunoablation, robotic, even AI, etc. However, novel is sometimes useless if it means the basic. Please remember the root of this tree. Because of excellent outcomes and the most minimally invasiveness and cost effectiveness, liver ablation finally survived in the most treatment guideline, as you can see like this. So I think it is time to be more deep positioning by strategic optimization. Thank you for your attention.
Thank you, Professor. Very thoughtful presentation. Are there any questions or comments from audience? I have one question. Okay. What technology improved the accuracy and efficacy of RFA or microwave?
Yes, a very long-standing question, but I think nobody knows. But Dr. Liang Ping over there, she performed a very nice randomized control study. If there is a strong evidence that there is a real survival benefit of microwave ablation over radiofrequency ablation, definitely we should consider microwave ablation first. But at the moment, there is no sound scientific evidence for survival benefit. So that's why my answer is depending on the operators. If you prefer, if you keep our basic things today I mentioned, I think the result will be not so much different, I think. Yeah, the energy doesn't matter, in my opinion, okay?
Professor Tanaka.
Tanaka from Japan. Thank you, Rim. Very comprehensive, nice talk. But time is up. It is very important opportunity to hear your opinion of experts. So I asked to the photographer to take a photo together. First shot should be a moderator and the speaker, and the second shot was all together. So do you help me? Okay? Yes. Okay, why don't you?
Okay, thank you. I would like to close this session. Thank you very much.
Thank you, moderators and lecturers. We will start the next session from 10:50. We will start the next session from 10:50.
はい、お写真なんですけど、舞台から下に向かって撮ると移動が少ないので、この後のセッションも考えて、ちょっと下で撮れればと思いますので、はい。So we're going to take photo from the stage to the seats. So please be seated. Thank you.
Now is the time to take photos. Please take your seat, and the photographer take your photos from the stage.
僕大学出るの。噂はあります。都会の町とか。